Okay, so this section is going to look at your vitamin K clotting agents, which is essentially warfarin or the brand name Coumadin. Um, and these are long, long history of drugs, which are great anticoagulants. And there's a lot of pharmacology here. So this is really a good place to kind of go over this. And so let's get into it. Um, so here's the vitamin K cycle, and vitamin K is really important in a lot of different things physiologically, but mainly really in terms of the coagulation component. Vitamin K feeds into the coagulation cascade pathway quite readily, and there's a lot of components to this cascade. And if you remember back from biochemistry, um, there's a main component of vitamin K in terms of the production of the coagulation clotting factors, all those clotting factors with the Roman numerals. Central to this is the vitamin K cycle, and central to the cycle is this one specific enzyme called the vitamin K reductase. The abbreviation is VKORC1, and this really basically shows the pathway here where you look at vitamin K, and this enzyme plays a key role in the conversion of oxidized vitamin K, which is 2,3-epoxide, to reduced vitamin K. And then this particular pathway feeds into this particular cycle where we're looking at, this proenzyme to this enzyme is really looking at the coagulation factors. And then here's the chemistry behind it in terms of specifically warfarin. And so warfarin is a inhibitor of this specific enzyme. And there's a chemistry component to this where the S enantiomer of warfarin produces this warfarin molecule, and the R enantiomer of warfarin produces these two molecules, actually these three molecules, under the direction of this group of specific CYP enzymes and this specific CYP enzyme. So there's a lot of different pharmacology here and a lot of potential for drug-drug interactions, which is why warfarin has such a narrow therapeutic index. Okay, so this is a really interesting story. We're going to take some time to tell it because I think it's fascinating. Basically, they had identified Coumadin, or the brand name warfarin, after a whole bunch of cattle eating a specific plant called sweet clover, which grows here in the Midwest, especially the northern part of the state and as well as Wisconsin. These cattle just dropped dead. And when they had taken blood of these animals to figure out what had caused this, they originally thought it was an infection. The blood was taken, put in test tubes, obviously, and then brought back to the laboratory. The blood never coagulated. And so they thought that there was some type of weird virus that was like turning these cattle into like zombie cattle. So they did a little bit of investigation, and they found that this particular sweet clover, which is really a weed or a prairie plant that grows, native throughout the state, has a high amount of this particular compound called dicumarol. And that was really kind of where this brand name Coumadin came from, because this compound had never been identified before. The researchers working on it basically called this drug Coumadin because of this compound that they had identified, and we didn't know what to do with it. And so, this was an agricultural institution. This actually happened in the University of Wisconsin, and they had found that when you give this particular compound to rodents, it killed them. So for a while, warfarin or Coumadin was really kind of given as a rodenticide to really maintain a rodent-free farm environment. And this is actually discovered and actually patented by the Wisconsin Alumni Research Foundation, or WARF, and that's where the warfarin name came from. So that's pretty cool. So it didn't really, we didn't really use it in humans for a long time. There was an Army inductee who I can't remember the story. Either he was drafted and he didn't want to be drafted, or he had signed up for the Army and he didn't get the position that he wanted. So he wanted to commit suicide, and he grabbed some rat poison, and he didn't die, but his blood was super thin. And so when they had found him, his blood was really thin, and then that kind of got the theory going that, oh, there might be some therapeutic um, usefulness to this drug. And so we knew that there were a whole bunch of patients that had quote unquote thick blood or hypercoagulated blood. So this would be a great drug to kind of develop and thin the blood. And so that's kind of how the oral preparation of this drug came about. So it's an interesting story. Um, Sad in terms of the Army inductee. I don't think he actually committed suicide, but he definitely tried to. But all those poor dead cows and this poor Army inductee and countless dead rats really kind of brought this drug to human consumption. So let's look at how it works. And so officially, it's called an antagonist of vitamin K, um, or and it's a racemic mixture. So it's got both R and S enantiomers. Remember that from organic chemistry. So there's like a left side and a right side warfarin. Um, and what it does is that it inhibits the conversion of oxidized vitamin K by reducing the activity of that vitamin K dependent enzyme. And so if you inhibit that excuse me, if you inhibit that enzyme and if you inhibit the production of the reduced form of vitamin K, you're going to severely restrict that coagulation cascade because almost all of those coagulation factors 2, 7, 9, 10 rely on vitamin K as a cofactor for the enzyme biological conversion process activity. So it's got a lot of different mechanisms of action because it actually inhibits all of the factors differently because all those factors are basically made at different rates and at different concentrations. So, officially we say this inhibits the production of the vitamin K dependent clotting factors, which are all produced in the liver. And so in terms of its half-life, it inhibits thrombin, or factor 2, between 60 and 100 hours. It has a dramatic effect on factor 7, with a half-life of 6 to 8 hours, and the other half-lives are listed there. So it affects at least 4 different coagulation factors at different half-lives severely. Now, it also affects protein CNS, and this is extremely important clinically and physiologically, because remember, proteins CNS are your anti-clotting factors. And so that's a key concept here. Please remember that, because this is the justification for basically putting patients on heparin first, then warfarin. Okay, you cannot start a patient on warfarin alone because you need heparin on board because you need to establish an anticoagulation um, outcome or phenotype in these patients. Because what's interesting is that when you first administer warfarin, the drug gets extremely thick, the blood gets extremely thick, and that's because the drug has a profound effect on the anti-clotting factors, which is, exactly the opposite of what we're trying to accomplish. We don't want to alter or inhibit these proteins CNS. We want to inhibit these, okay? But what we see, especially in naive patients and naive animals, is that you see a dramatic inhibition of protein CNS first, followed by an inhibition of clotting, the pro-clotting factors. So that's really a central concept or dogma to remember. To get heparin first, and then as the patients become anticoagulated, you can start warfarin therapy, of course, which is orally administered, and then you can produce a nice coagulation. Clinically, this is referred to sometimes as bridging. Okay, and sometimes there's a coagulation pharmacist who you can page and they will help you bridge a patient appropriately. Understand too that warfarin has no effect on the existing or circulating clotting factors, which is another reason why you can't just start giving warfarin immediately and immediately expect that the patient will be in a clot-free state. Okay, so this takes some time to establish a therapeutic relevancy. Okay, and then just as kind of a nice review or summary, here's your coagulation factors or the Roman numerals, and then there's a synonym. And so if you ever look in the literature, if you ever go into hematology specifically, these are what those Roman numeral factors are also called. So factor 10 is called Stewart-Prower factor. Factor 9 is sometimes called the Christmas factor, not because it was discovered on Christmas, but the person's last name was Christmas. Factor 7 is called proconvertin, and of course factor 2 is called prothrombin. Okay, and then just to kind of complete the table, I filled in the right-hand column here, which is the drug targets that can inhibit it. So remember, both heparin and warfarin can inhibit the activity of factor 2A. Warfarin inhibits the synthesis of factor 7, warfarin inhibits the synthesis of factor 9, and now both heparin and warfarin inhibit the synthesis of factor 10. Okay. So again, here's that coagulation cascade. And if you look at all of these factors that are inhibited, 2, 7, 9, and 10, okay, and then find 2, 7, 9, and 10 on this chart, you can see warfarin has a lot of inhibitory effects on this coagulation cascade, and it's quite potent. Okay, small amounts of warfarin will dramatically reduce this cascade and produce blood that is essentially thin. Okay, excuse me. And so, clinically, where do we use warfarin? A lot of different places. We can use it to inhibit and treat deep vein thrombosis and pulmonary emboli. Of course, after heparin's been initiated. We can prevent another venous thromboembolism from occurring. We see this a lot specifically in orthopedic and gynecologic surgeries. We can see it in patients that have recurrent coronary ischemias, in acute myocardial infarct. Although heparin and warfarin are not kind of like the standard of therapy post-MI, you can definitely see at least heparin used during the stent placement. You can see warfarin implemented for maybe 3 months in patients that have a high risk of developing blood clots, and that's due to basically the history. But if you just take a regular STEMI patient, most STEMI patients don't really need warfarin post-STEMI. Typically, the aspirin and the clopidogrel is usually enough. These would be patients that maybe they recently had a STEMI, but they've also had a history of TIA or stroke, and they may have some underlying AFib, or they may have had a DVT. So those are the patients, with STEMI that you'd be a little bit more aggressive and maybe put them on warfarin as well. And then of course patients that have had major heart surgery, inserting prosthetic heart valves and so forth, chronic AFib, warfarin is definitely one of the main therapies for managing and treating atrial fibrillation so that they don't develop systemic clots. A lot of pharmacodynamics. There's well-known genetic polymorphism, specifically in the CYP2C9 enzyme, and that can greatly influence warfarin biotransformation and metabolism. Almost all of this drug is completely bound to plasma proteins, and so a change in the plasma protein compartment will affect blood concentration levels. The drug does kind of go into the albumin space, and so whenever there's a volume expansion or contraction, which is followed by a change in the amount of protein, specifically albumin, you can also see alterations in therapeutic management of warfarin, excuse me. And a lot of the metabolites that are inactive, and there's several metabolites that are produced upon biotransformation, a lot of them are excreted into the urine and the stool. Lots of drug-drug interactions. Basically, if you've got a patient on warfarin, you can pretty much guess that there's going to be a drug interaction with any other drug that you prescribe. The drug interaction list is long and extensive. A lot of it's due to biotransformation components, including the CYP enzyme system. And there's also some drug-drug interactions too in terms of structural interactions. And I think for the sake of time, let's end here for this lecture. We're going to talk about protein CNS in the next video because it's an important concept. I want to bring it back. So that was a little bit of the background pharmacology on warfarin, and we'll end there.